Good afternoon, everyone. My name is Branca. I work at Chelsea Westminster Hospital, and today I would like to describe our experience in managing cardiovascular risk in our cohort of patients living with HIV over the age of 50. So current guidelines recommend that cardiovascular risk assessment should be part of the routine management of people living with HIV. There are several risk assessment tools available. The UK guidelines recommend the use of Q-risk score to predict the 10-year risk of developing cardiovascular events, because this performed better than the Framingham score in the UK general population. However, both scores have been validated in the general population, so they may underestimate the risk in people living with HIV. Alternatively, HIV-specific cohorts, such as the one derived from the DAD study, may provide a better predictive value of cardiovascular risk in this population. However, this score has yet to be validated externally of the cohort. And then we also have coronary artery calcium CT scoring. So in recent years, it has been suggested that the CT scanning of the heart may provide a better predictive value of cardiovascular risk as compared to the previous screening tools. So basically, this is an imaging study that allows the detection of subclinical atherosclerosis. It detects the amount of calcified plaques in the three main vessels of the heart, and it provides with an absolute calcium score, as well as a centile, where the patient stands in terms of vascular age as compared to age and gender-matched controls. So in our hospital, we have a dedicated clinic for all the patients over 50 years old, and we are lucky enough to offer this exam to all asymptomatic patients. And according to the centile where these patients are placed, if they're above the 5th centile, they should be offered preventive strategies. So if they're between the 5th and 75th centile, we offer him statin treatment for an aggressive lipid control, as well as lifestyle modifications, as well as consideration to change the antiretrovirus to a more cardioprotective regime. But if they're over the 75th centile, we refer them to cardiology. And now we've created this joint HIV cardiology clinic to allow a prompt assess and review of these patients, not only with a high CAC score, but also with other high-risk conditions of cardiovascular disease. So we performed a study, a retrospective analysis between May 2017 and April 2018, to analyze the concordance of the results between CACs and the traditional risk scores, Q-risk and Framingham. So during this period, 103 patients underwent a CT score, and 33 of these patients were 33 of these patients, 32% had abnormal results. So they were placed above the 5th centile. So you can see from the demographic table that the patients with higher scores, they are more likely to be older, as expected, more likely to be smokers, diabetic, slightly higher systolic blood pressure, and as expected, the cardiovascular risk calculated either by Framingham or Q-risk was higher in the patients with higher CAC scores. However, when we went to compare the correlation of CACs and Q-risk or Framingham in each specific patient, we found that among the 33 patients that had abnormal results, 14, highlighted in red, had a Q-risk score below 10. So they would have been placed in the low-risk group and would have been missed and offered the strategies to prevent cardiovascular risk. And the same was found with the Framingham score. So both scores actually performed really in a similar way in our cohort. So in conclusion, from our findings, what we want to highlight is the fact that traditional risk scores may indeed underestimate the risk, and they may fail to detect patients with subclinical atherosclerosis that may only be detected with the CACs, and this supports the use of this screening tool in our clinical practice. Thank you very much.